Very quickly, I'm 71 Echo Clinical Lab Officer. I started off as an E1 as a 68 kilo medical lab technician. I know we have some MLTs and it's okay, you don't have to identify yourself, it's all good. And I commissioned about 10 years ago, so I've been in the military a little over 24 years. And so being in as long as I have, I understand military institutional training, okay? I've been in your, not necessarily being a PA, but I've been in enough schools to know what you need, okay? So I'm gonna cut out all the extra stuff. I'm gonna get, because what I need for you all to understand is when it comes to lab, I don't expect for you all to be SMEs. I'm the SME, okay? So utilize what our services as lab, utilize us. You take care of the patient. If there's something that's just way above and it's too science, too much in the weeds, I want y'all to understand that you can come to us and we can help you all out, okay? All right, so 7 weeks with me, right? We're gonna start off today just kind of going over the basics, a little bit of hematology and hemostasis. For block 2, we're gonna start in the next couple of weeks. We'll go more into panels, chemistries, and urinalysis. For block 3, we won't start that till about November. We're gonna go more into micro. So as you all got the introduction to micro in freshman year, sophomore year, I want you all, this is where we're gonna learn how do we test for those bugs that you learned about. And then block 4 will be in December, so right before block leave. You're gonna have me right before you go on leave. We're gonna go over blood banking, walking blood banks, and a little bit of toxicology. All right, so do you have any questions before we move on? Okay. So I'm trying to get used to this over here because I don't like being behind the podium, but it's okay. So y'all know how to read TLOs. I don't have to read that to you. You know how to read ELOs. And you know your reference and where to find that, okay? So this is gonna be based off chapters 1, 2, 3, 8, and 65. So this is just an introduction scenario. I don't expect any of y'all to answer it, but I want you all to kind of get in this mind frame. This is, when you get tested, this is how I'm gonna present it to you. A 52-year-old man presents with fatigue, joint pain, and a history of hypertension. His provider reflexively ordered a CMP, a CBC with differential, ESR, CRP, thyroid, vitamin D, and ANA. Most values are normal, but the CRP is mildly elevated. After unnecessary referrals and imaging, the true cause was iron deficiency anemia from a slow GI bleed, what eventually discovered through a focused CBC and an iron panel, okay? So just know I'm gonna present you with the age, gender, I'm gonna give you a little bit of, maybe a little bit of medical history, and then we'll go into different types of tests. Now this obviously said this person has iron deficiency anemia, but I will have that answer in the questions on the test. All right, so what is the role of the clinical lab? To identify, to diagnose, and to manage conditions of your patients, all right? So we use detection and biomarkers. So our most common things would be like glucose, cholesterol, tumor markers. We identify different pathogens, different parasites, different fungi and viruses. We also look at different types of blood cells, so red blood cells, white blood cells, or platelets. And then you also use it to monitor for treatment response as well. And lastly, to educate other staff and collaborate with other staff. So, ordering tests is paramount to you all, because a lot of times when your patients come into your clinic, all right, come into your office, based off of their history and whatever they're presenting, you kind of already know what's going on with them. You utilize the labs to verify, right, or to confirm what you've already diagnosed, okay? That's really what I want you to get off of this slide. Okay, this is such an important slide. It's so important that you might see it again, okay? So, types of blood specimens: whole blood, serum, and plasma. So whole blood is a mixture of your red blood cells, your white blood cells, and your platelets, okay? And this is what closely resembles what's circulating in the body. And then you have the serum. The serum is that liquid portion of that blood. Serum does not have any coagulated proteins in it. And then lastly, you have plasma. Plasma is treated with those anticoagulants, and depending on where that you collect the blood, depending on what tube it goes in, there could be anticoagulants in that blood. And pretty much that keeps everything from clotting up, and so that your laboratorians can go ahead and test that plasma. So what I want y'all to get from this is to know the difference between whole blood, serum, and plasma. All right, and this is just another visual breakdown of what that looks like. Now granted, when blood is collected in a tube, it does not look like this. It has to be placed in a centrifuge first, spun down, and then those four elements will fall to the bottom, and then that liquid portion will be on the top. And the liquid portion is what we usually use to run our tests on. All right, so this is some blood sample submission frequency. Anytime you see stuff like most common, anything like that, just know you're gonna see it again, okay? So our most common is venous blood. So anybody that's been to the blood draw room, of course, they go ahead and stick that arm there, the median cubital vein, and that's where majority of our tests come from. Our second most common is your capillary blood. So that's usually from glucose sticks like the fingers. A lot of times it's the heel sticks for the babies when they're first born, or for those burn victims where they can't have access to those veins. And then lastly, we have arterial blood, which comes from the arteries, right, in the wrist and the femoral groin, okay? And you'll see a little bit later on in block 2 where we'll talk about acid-base statuses. All right, so what will the lab tests show? It's just a snapshot of your patient's health at that time of collection. For our reference ranges that we utilize in the lab, it's based off of our local population. So what 95% of the population is displays is how we determine our reference ranges for each lab. So I do not expect for y'all to memorize reference ranges. I will provide you with reference ranges because it does vary from lab to lab, okay? So on your exams, I will provide you with a reference range, I will provide you with the result, and then you all have to determine what that patient has, okay? So we know this is based off evidence-based medicine. This is all throughout the military. This is also applies to lab as well. So clinical experience, scientific research, patient values, and preferences. This is the framework to all medical decision making. Oh, this is another important slide, y'all. Very important. So when we talk about overutilization of lab tests, what we mean by that is a lot of times you have these patients that come to the ER, you don't know what's going on with them, and y'all just order a rainbow of labs. Just order stuff. Don't do that. Please don't do that. It's wasteful, okay? And a lot of times you end up getting results and you can't really pinpoint what that patient has. So that's what we mean by overutilization of testing. If you see a patient that is displaying certain symptoms, whatever that may be, make sure that you're ordering the right test to kind of pinpoint what you're looking for, okay? This is harmful to the patient, and sometimes, it can lead to other things that you don't need to look at. Let's just put it away. But again, like I said, very important slide. All right, so how to reduce that? Education and training, which y'all are doing here. Make sure that you're talking with your fellow clinicians. Utilize your laboratorians. Utilize your pharmacists. Utilize your resources around you, okay, before ordering tests. So this is just an example of redundancy. So CRP and ERP. So C-reactive protein and erythrocyte sedimentation rate pretty much are two tests that test for inflammation, which is very, very generic, right? So one CRP is one you'll probably see more often in a medical center, while the ESR is something you'll see more in clinics. But it's just an example just showing you, these are two tests that test for the same thing. And it's one of those things where have that discussion with your other providers, with your other medical personnel to know which is the best test to run if you're looking for inflammation in a patient. Okay, so we're gonna briefly talk about panels, okay? And you know what, we're 14 minutes in and we're already halfway through. All right, so this is just a breakdown of like how the lab is set up, okay? Everything in red there is what I'm gonna be introducing to you all for the next 7 weeks. You have your head honcho, which is your doctor, your medical director, and right underneath that, you got me, the laboratory manager. So that's me, the medical laboratory scientist, all right? And underneath that, we usually have 3 sections: the anatomic pathology, our support services, and our clinical pathology. For this PA program, we're gonna focus more on the clinical pathology side. And if you look underneath that, you have micro, hematology, urinalysis, serology, chemistry, and immunohematology, okay? Micro will be till block 3. Hematology, we're gonna touch a little bit on in the next couple days. Your UA is block 2, serology is block 4, chemistry is block 2, immunology is block 4, okay? But again, I'm gonna tell y'all what you need, all right? It's a lot of information, but I'm gonna tell you what you need to know and what you will be tested on. All right, so these are just understanding lab panels. So we're gonna get really big into lab panels. You'll see a lot of panels. It can be a bit much, but I will make sure to not overwhelm you too much, to make sure that we can get you to diagnosing your patients correctly. Okay, so if you look at that clinic scenario, it says a stable patient admitted with fatigue receives a CMP. CMP is a comprehensive metabolic panel, and the results show a normal electrolytes, but elevated AST and ALT. This prompts a further liver workup. The panel helped detect undiagnosed liver injury. Oh, this is another lovely, lovely slide. It's so beautiful. In fact, you'll probably see a couple of questions on this one, okay? So, hematology panel consists of the complete blood count, all right? When we talk about complete blood counts, we're looking for anemias or infections. So urinalysis, that's in yellow there. Urinalysis panels consist of your UAs and your microscopics. You all as PAs, I know a lot of you all probably do not like to look under the microscope like I do, but because you are providers, there may be times that you may have to look under the microscope for urine, okay? And we were gonna get into that a little bit more in block 2. All right, so for UAs, you're looking more for urinary tract infections and kidney disease, and then serology panels are big with our STD testing and HIV testing. All right, so chemistry, we're gonna go a little bit into that. The basic metabolic panel, the comprehensive metabolic panel, the renal function panel, the lipid panel, and liver, okay? So those top 4 are really common. You'll definitely see that, especially in those routine checkups, especially for those that need to, are taking medication and they're looking to get a refill on their prescriptions. A lot of times you would have to run like a liver function to make sure that they're processing those medications and it's doing what it's supposed to do. Also, for those that are on cholesterol medication, you want to provide or run those lipid panels on those. Anybody that's taking any type of hormone or thyroid medication, you want to run those thyroid function panels on those patients. Oh, and also, okay, here it is. Another beautiful slide that you all will see again, okay? You will be tested on this stuff, all right? But we're gonna go more into micro in block 3. But microbiology, we're basically gonna take all those bugs and all those viruses and all those parasites that you memorized as a freshman, and we're gonna apply that to lab, all right? How do we test for those? How do we see those? And what does that look like in patients that have these things, right? And then hematology, that's about identifying the blood types, and I just saw Major B, I guess he was going over that with you all. So I think you got a lot of that in pathology, so I will not keep, if you all got it down, we'll do a quick overview, but just know you'll be tested on that as well. All right, so here are some common anticoagulants. So remember I said you all need to know the difference between serum and plasma, right? So any time blood is collected in those tubes, they have anticoagulants. So that would be plasma that we're testing, okay? So you have your purple top tubes, which is your EDTA. That's where we're gonna do our complete blood counts off of those tubes. Green top tubes, you see a lot in chemistry, consists of heparin, and a lot of osmotic fertility testing is done on those. And then your light blues, which consists of sodium citrate, will be used in a lot of our coagulation studies, so PT, PTT, and INRs. All right, so this is a basic metabolic panel, right? This consists of 8 tests. So you see how it's all listed there? I have it written out and I have the abbreviation. So make sure you know both, because you may see it as both on your test, okay? And then there's just an example there, an MHS Genesis example that you all may see. If you order this test on one of your patients, that's how it's going to be presented to you. And if you kind of look closely, you see how the reference ranges are already, the reference ranges are there, and that's how I'm going to have it on your test. So I'll have a reference range with the results, and then you just get the right answer from there. So BMP is very important. CMP, that's another one that's very important. So that's the 8 tests along with a couple more. So this is a total of 14 chemistry tests. So on top of what you get for the BMP, you also have the albumin, the ALP, AST, bilirubin, ALT, and TP. Now, like I said, this is just an overview today. We're going to get more into what each one of them means and what that looks like and how that's presented in your patients. All right, and this is just a side-by-side of what a complete blood count plus a differential looks like. So on the right side is a civilian example, and then on the left side is what us as military people will see if your organizations are all up on MHS Genesis, which I think everyone is. So this highlighted here, the CBC portion, which is the complete blood count portion, just kind of breaks down the white blood cell, red blood cell, hemoglobin, hematocrit, and there's these 3 M's, right? MCV, MCH, MCHC. We're going to get more into that. That kind of goes into how what those red blood cells look like, how they look like, how they're presenting. And then on the bottom, that differential portion, you all will not see differentials, but you all need to understand what they are. Differentials pretty much just break down what kind of white blood cells are in that blood. So if you have a patient that has elevated white blood cells and it flags the machine, then we have to do what's called a differential, where that blood is put on a slide, and then we have a laboratory look at it under the microscope and then determine what kind of white blood cells are in that blood, and that'll help diagnose or what, help you find out what your patients have. All right, so urinalysis, this is very similar if you've ever done any type of like water testing, like you test the pool, it's kind of the same concept, where you just take that strip and you dip it into the urine, let it sit for about 30 seconds, and then each one of those little pads will change a different color to indicate what is in that urine, okay? So this is also a very important slide, okay? And I'll present it the same way, where I will have the chemical analysis, I will have the results, and then the normal values, and then I would need for you all to determine what that patient has, okay? So, glucose, you'll definitely see in those that have that high blood sugar, if anybody's on medication, glucose will be really important. Bilirubin is determining if somebody has jaundice or hepatitis. Ketones, we have a lot of fit people in here, right? And we got a lot of people that like to be on that keto diet. And I know I've heard other instructors talk about it, but yes, you can tell when somebody's on a ketone diet and they're working out a lot of times their ketones are very elevated. Specific gravity, those are the normal values. Blood, it's supposed to be negative, but sometimes in menstrual women you'll see blood, or somebody has some type of kidney disease or some type of injury, you'll see that elevated. Protein is another one for all of those that like to lift and like the protein drinks and stuff, sometimes you'll see that elevated as well. Urobilinogen is just that breakdown of the bilirubin. Nitrites is actually bacteria, okay? And so sometimes when you see an increase in nitrites, especially if it's submitted correctly, somebody may have an infection in kidneys, but also if urine stays out too long and it's not tested within a normal amount of time, you can also see falsely elevated nitrites. Okay, and then lastly is leukocyte esterase, and that is just white blood cells that we can also see in the urine. This is an example of a UA panel with a microscopic. Nothing interesting here. All right, pre-collection variables. Okay, so just take into account, these are the types of things that affect your lab results. Gender, obviously. Hemoglobin tends to be a little lower in women than men. You gotta take into account of age and the type of testing you provide. You're not gonna run the same panel on a baby as you would like the senior citizen. Race, they're African Americans tend to have that sickle cell variant. Definitely take into account medications, and a lot of times, depending, especially if they're on warfarin or Coumadin, please let your laboratorians know, because that does affect the testing. And then just adhering to actual preparatory instructions. So for those that are on cholesterol medications, and we need to get a baseline of their lipid panels, please let your patients know they need to be fasting 8 hours prior to eating, 8 hours prior to getting their lab results, because when they eat, that does elevate those lipid panels, okay? So you could have falsely high triglycerides or cholesterol, LDL, things like that. All right, and this is just saying that some tests are good to run in the morning, some are good to run in the PM. So I'm not gonna really test you on that necessarily. I will indicate that already in your, I will already indicate that if I put it on as a clinical diagnosis on your exam. But this is just saying, you know, blood pressure tends to be lower in the morning, and cortisol tends to be, you know, decreases throughout the day, things like that. Another very important slide. So important, in fact, there's gonna be like 2 or 3 questions off of this one. So exercise is important, because you all, when you get to your first duty stations, more than likely will be at like an aid station, right? And so a lot of those times, you tend to be open during sick call hours, and you tend to get a lot of those PT injuries that come in. So just take that into account before you start drawing bloods on these service members, because you could have some falsely elevated results if they had just got done with PT. So like an increase in CK and AST and LD, that's cardiac markers. So we already know that their heart rate is pumping and things like that. And we don't want to pull a lab on a service member that just got working out, and that, you know, when they don't have anything going on with them in their cardiacs. Of course, diet. We know glucose and triglycerides will increase after eating, and protein-rich diets will increase your BUNs, ammonias, and urates. And stress, right? Stress can increase your cholesterol and lower your HDLs, right? We're almost there, y'all. We're almost there. Posture. That's just nice reading. I'm just gonna keep it real. All right. Age. Bilirubin concentrations will increase after birth. So for any of those that had babies, and when the mom was in there with the baby, they're always coming in and sticking the baby's heel and rubbing the heel of the little circles. They're just checking the bilirubin of the baby and ensuring that the baby doesn't have jaundice. Okay, another important slide. Testing sources of error. It is really important for you all as clinicians to submit the specimens accordingly, please. We really don't like rejecting specimens, okay? So hemolysis. Hemolysis is when you have the RBCs get cut up, right? I always say cut, but they get sliced up, and then so you have all this hemoglobin and stuff in the liquid portion of the sample, and a lot of times that can cause some elevated results, okay? But if there's hemolysis, and it is going on internally with that patient, that could indicate a hemolytic crisis or a G6PD deficiency. So lipemia, I think it's in the name, lipids, right? An increase of that. A lot of times we can tell when somebody is lipemic, because before we even spin down the lab, a lot of times it'll look like strawberry milk, like whose blood looks like strawberry milk. So a lot of times we can tell before it even gets spun down that somebody has a lot of fats in their blood. And that could be an indication of cardiovascular disease or acute pancreatitis. You have icterus, which is excess bilirubin, and that kind of looks a little dark yellow, kind of greenish in that serum or plasma, okay? And that could indicate some type of cirrhosis or hemolytic anemia. And so you see hemolytic anemia, that comes up a lot, okay? So we'll get more into anemias a little later, but for whatever reason, this program really likes to harp on that. So anytime you see hemolytic anemia, just know that you're gonna see it again. Clotted samples, that comes from platelet pumping. And again, like I said, we don't like rejecting samples, but if it comes as clotted and it's not supposed to be clotted, we don't throw it in trash, I'm sorry. You don't have to redraw, okay? Rouleau is when you have an abnormal stacking of RBCs. That could be associated with plasma cell disorders, and lastly, cold agglutins, which is the risk of hemolytic crisis and cold agglutinin disease, okay? So again, like I said, very important slide. And now we're at our ELOs, and now we're at questions. I hope y'all don't have any. But if you do, please ask. But that is it for today, seriously, that's it.